Well, thank you to Aberdeen Anaesthesia for filming this dissection of the pig heart. I'm Mr. Buchan. I'm one of the cardiac surgeons here in Aberdeen, and here is our pig heart. I want to start just by looking at the external surface of the heart. And we can see that there is a convex side to the heart, this part here, and there's a more flat part underneath, which is the inferior surface of the heart. So we have a superior surface and an inferior surface, or an anterior surface and a posterior surface. And we have an apex and a base of the heart. And at the level of the base of the heart, we have the great vessels coming out from the right ventricle and from the left ventricle. So this is the pulmonary trunk, and this is the ascending aorta, becoming the aortic arch, where it gives rise to the branches which go to the head and neck. This is the left atrial appendage. This is the right atrial appendage. These are called auricles in some of the anatomy textbooks, which is the Latin for ears, and they do have a sort of ear-like resemblance. There are a few cuts on the surface of the heart. These are just butcher's marks from when the heart was taken out of the animal. I'd like to spend a moment or two just talking more about the external surface of the heart. So in life, the heart lies something like this, and this would be the front of the chest. When we have penetrating cardiac injuries, they usually hit the right side of the heart. At least the ones that reach hospital alive have usually hit the right side of the heart. And they most commonly involve the right ventricle, the right atrium, but they may also involve the left ventricle or the left atrium, or any of the great vessels that are attached to the heart. We talked about the pulmonary trunk and the ascending aorta, but on the back of the heart, we also have the pulmonary veins. These are some of the pulmonary veins that we can see here. And we also have the superior and inferior vena cava, which are not always immediately apparent, but let me try and show them to you. So this is the superior vena cava, and this is the inferior vena cava, and I have connected the two vena cavae with the forceps. So behind the inferior vena cava and the right atrium, we have the two pulmonary veins from the right lung. Well, this is a pulmonary vein. I think this is a pulmonary artery. So let's come back to the external surface of the heart. We have these interventricular grooves running down between the right ventricle and the left ventricle. This is the anterior interventricular groove. And on the undersurface of the heart, there's a corresponding posterior interventricular groove. And there are arteries that run within these grooves. So on the undersurface of the heart, we have the posterior descending coronary artery, and on the anterior surface of the heart, we have the left anterior descending coronary artery. And there is a third coronary artery, which is called the circumflex coronary artery, and it runs in the atrioventricular groove. The atrioventricular groove is a much less well-defined anatomical structure, but it runs between the ventricle and the atrium. And on the right side, we have the right coronary artery running in that groove. And on the left side, we have the circumflex coronary artery running down just in front of the left atrial appendage. It's quite difficult to see the main circumflex coronary artery, and it can be tricky to find it if you're trying to graft it. But generally, the best place to find it is in front of the left atrial appendage. The left anterior descending coronary artery gives off little branches which pass into the left ventricle, and these are called the diagonal branches. And it also gives off branches which we cannot see from the surface, but which penetrate deep into the septum, and these are called the septal coronary arteries. The circumflex coronary artery gives off a number of branches which go to the left ventricle, and these are called the obtuse marginal coronary arteries. So when we're doing coronary artery bypass grafting, these are the vessels that we graft into. The more prominent vascular structure is the coronary vein, but the coronary artery is the collapsed, paler structure running alongside. So the coronary veins coalesce into the coronary sinus. Here you can see the beginnings of the coronary sinus, called the great cardiac vein, in the atrioventricular groove on the left side. And as it comes around, it becomes larger in size until it drains into the right atrium. We'll have a look at that in more detail later, once we open the heart. So let's have a look at these great vessels again. You can see how they cross over at right angles to each other. This is the axis of the pulmonary trunk. And if we had lifted this off, the pulmonary trunk away, we would see that the axis of the aortic root and the ascending aorta would be in this direction. So in transposition of the great arteries, you have the pulmonary trunk arising from the left ventricle and the aorta arising from the right ventricle. And in that condition, it's quite striking because both of the great vessels are running parallel to each other, as it's seen with the naked eye. So I'm just going to show how to do a dissection of the heart, and would encourage cardiac surgical trainees to purchase their own pig hearts, which you can get from various companies, such as Medical Meat is the one that we've used today. So what I'm doing just now is just separating out the pulmonary trunk from the ascending aorta, and there are these little ligaments which attach the two structures together, and eventually we'll get in behind the pulmonary trunk. Here we are. So for our dissection of the heart, we separate the pulmonary trunk from the ascending aorta, and then we transect the pulmonary trunk. And this allows us to get good access to the ascending aorta. And if we were to dissect into this gap between the pulmonary trunk and the ascending aorta, we would soon come to the coronary arteries. But we won't do that just yet. So the pulmonary valve has got 3 leaflets. It's a tri-leaflet valve. And there are a left, right, and posterior pulmonary valve cusps. And there are corresponding sinuses of Valsalva, or pulmonary root sinuses. And what we're aiming to do is to cut roughly down between the right and the left pulmonary sinuses into the right ventricular muscle. We'll often find that there's some blood clot in the heart when we open up a heart like this. So now you can see the pulmonary valve leaflets. Exposed. So these are what are called semilunar valves. They're like half moons. And very thin translucent material here. We have in fact damaged this cusp in cutting open the pulmonary root, but you get the idea. This edge would have been connected to this edge. So we'll open the right ventricle a bit more. And here's a fairly constant feature of the right ventricle, with this thing called the moderator band, and it usually contains the right bundle of the conducting system. We have a system of specially adapted myocardial fibers called the Purkinje fibers, and they deliver the electrical impulse to all parts of the heart in a coordinated manner. Initially, the bundle forms the interventricular septum, just where the interatrial septum becomes the interventricular septum, and then we have the bundle of His, which divides into a left and a right bundle. And the right bundle passes into the free wall of the right ventricle through the moderator band. So for the purposes of our dissection, we're going to remove much of the right ventricle, but as we do so, we will see the tricuspid valve in some detail. So we'll just chop away some of the free wall, including the moderator band. And we shall open the right atrium just now. So I'm opening it along the line of the inferior and superior vena cava. And I shall trim back the right atrial appendage. Here is the anterior leaflet of the tricuspid valve, and it is the main leaflet, is analogous to the anterior leaflet of the mitral valve, and has a similar pattern of collagen fibers, and it's slung between two papillary muscles. There's an anterior and a posterior papillary muscle in the right ventricle, and there are these parabolic curves of collagen within it, and we have a septal leaflet as well in the tricuspid valve and an inferior leaflet, and together these are analogous to the posterior leaflet of the mitral valve. So here is the tricuspid septal leaflet, and the inferior leaflet is just this piece of tissue that's down at the bottom. So anterior and posterior papillary muscles. You can see the inflow direction of the right blood coming from the right atrium to the right ventricle, and then there's this big muscular bar here called the infundibulum before the blood exits through the pulmonary valve. So of course in the left ventricle, as we'll see in a short while, there isn't a muscular bar between the inflow and the outflow. The two structures are very much contiguous with one another. I'm going to now just remove the remaining part of the right ventricle. Just destroying the anterior leaflet of the tricuspid valve, but we'll leave the septal leaflet in place. Now there's something I'd like to point out here, which is this membranous valve, it's called. And remember, we cut open the right atrium between the inferior vena cava and the superior vena cava. So this is where the inferior vena cava opening would have been. And there is this fold of tissue here which guards another orifice in here, which is the orifice of the coronary sinus. So this is the valve of the coronary sinus. It's sometimes called the Thebesian valve. And occasionally you have another valve hanging down from a sort of commissure up here. There can be another fold of tissue here called the Eustachian valve, which governs the flow of blood from the inferior vena cava into the right atrium, but it often disappears as the animal matures. But this Thebesian valve is quite important because it forms one boundary of the triangle of Koch. Robert Koch described the tubercle bacillus, but there's another Dr. Koch who described this triangle of Koch, and it is formed by the margin of attachment of the septal leaflet of the tricuspid valve to the interatrial septum. And you have to imagine that these are the two boundaries of a triangle, and at the commissure between the septal leaflet and the anterior leaflet, which we have removed up here, that's the apex of the triangle, and this is the base of the triangle, the Thebesian valve, and the anterior limit of the triangle is the attachment of the septal leaflet of the tricuspid valve. So there is the triangle of Koch. It's an important structure to be aware of, because if you were to, for some reason, open this triangle with a knife during operation, thinking that it was a way into the left atrium, you would find that you entered the left ventricular outflow tract. And if we open it, I'll open it for you now, just so that hopefully you remember never to do this in life. But if we were to think mistakenly that this was the fossa ovalis, which can happen, then what we actually end up doing is opening into the left ventricular cavity, and that can create a special type of ventricular septal defect called an atrioventricular septal defect, because it runs from the right atrium to the left ventricle. Now, I would like to open up the coronary sinus a little bit here, if I can, because there's some important anatomy to understand here for practicing cardiac surgeons, because we often put a cannula into the coronary sinus during heart surgery to retrogradely perfuse blood around the coronary circulation. And in the tissues of the body, the blood that's in the venous channels is about 5 times the volume of the blood in the arterial channels. And so by using venous retrograde perfusion, we cool the tissues much more effectively than we do with antegrade perfusion through the arteries. So it's a popular method of preserving the heart while we're operating on it. And a cannula is placed into the coronary sinus, and it has a balloon which expands so as to allow the blood to be perfused retrogradely without leaking back into the right atrium. But what you'll notice is that the coronary sinus has got a funnel-shaped orifice, and that funnel shape is continued for perhaps 2 centimeters into the structure, and thereafter it becomes tubular. You can see my instrument passing into the coronary sinus here. So if the balloon is where the tip of my scissors is, it will be good. It will work very nicely. And you'll see the pressure augmenting as the perfusion begins. But if the balloon is only here, sometimes you get valves in the coronary sinus, and it can prevent the balloon going in where you want it to go. So if it gets stuck just here and can't go any further, then when the balloon is inflated, it makes it eject into the right atrium. And so in cases like that, you may have to put a finger down between the IVC and the base of the heart and lock the balloon in place with your finger, and then you will achieve satisfactory retrograde perfusion. If I open it, maybe we can see the funnel shape that it has. So I've now opened the coronary sinus. And I think you get the idea that it's got this rather broad funnel-shaped opening into the right atrium, which is very important to know about if you're using retrograde coronary sinus perfusion as a form of myocardial protection. So I'm just going to trim a little bit more of the right ventricular remnant away before we open the left ventricle. I will also remove the aortic arch. So the sinuses of the aortic valve are easier to remember because of the coronary arteries. So they're named after the coronary arteries which are coming off them. So there's a right aortic sinus of Valsalva, a left aortic sinus of Valsalva, and a non-coronary aortic sinus of Valsalva. So in fact, the right coronary sinus of Valsalva lies anteriorly. The other two lie posteriorly, that is to say the left and the non-coronary sinuses of Valsalva. So in theory, what we're trying to do here is cut between the left and the right coronary arteries. And let's see if we can do that. And in so doing, I'm going to cut through the ventricular septum into the left ventricle. Okay. So here we have managed to cut quite well because we have preserved the leaflets, and what we have are the left aortic valve cusp, the non-coronary cusp, no coronary artery behind there. In the left ventricle there are two papillary muscles, and they are named for their relationship to the interventricular septum. So there's a medial papillary muscle and a lateral papillary muscle. And similar to the anterior leaflet of the tricuspid valve, but much more prominent is the anterior leaflet of the mitral valve, and it has these chordae tendinae running into the leaflet from the papillary muscles. And here we have the inflow to the left ventricle. I'll remove the left atrium so we can see that more clearly. So this is from the left atrium through to the left ventricle, and you can see that the outflow tract doesn't have a big ridge of muscle here, and that's what differentiates it from the right ventricle. No infundibulum here. Instead we have a thing called the aortomitral continuity. So the aortic valve at its junction between the left coronary cusp and the non-coronary cusp, we call this the left non-commissure of the aortic valve. So the cusps are hanging together from an anchor point here, which we call the commissure. So this commissure marks the axis of symmetry, if you like, of the anterior leaflet of the mitral valve. It's not a perfect axis of symmetry, but it's an approximate one. And if we were enlarging the aortic root, we would make a cut down from the aorta through this commissure, and then there are various ways of travelling once you get to the commissure, depending on which type of root enlargement you wish to carry out. So this is the anterior leaflet of the mitral valve. Again, the collagen fibres are disposed in parabolic curves into the leaflet, and some of them travel up in parabolas into the posterior leaflet behind. So there's an anterior leaflet, and we haven't seen it yet, but there's a posterior leaflet behind there, behind the back of the ventricle. In mitral stenosis, you get fibrosis of the valve leaflet and of the chordal apparatus, and the papillary muscles come much, much closer to the mitral valve than they should be. You may get incorporation of the papillary muscle heads into the leaflet tissue of the mitral valve in rheumatic mitral valve disease. And this process leads to a reduction in volume of the annulopapillary compartment, and is actually one of the main reasons for heart failure in that condition. So it's quite important in rheumatic mitral valve disease to divide the chordae so as to allow that compartment to enlarge again post-operatively. In aortic valve endocarditis, you can see how easily the process could spread to involve the mitral valve. And so if there's an infection in the aortic valve, most commonly the sites where you get maximum infection are the commissures, and that can spread very easily through the aortomitral continuity into the anterior leaflet of the mitral valve and cause what we call a drop lesion. So it's not rare to see aortic valve endocarditis with perforation of the anterior mitral leaflet, and it's sometimes possible to put a pericardial patch onto the hole and preserve the native mitral valve. Where the valve leaflets insert into the atrioventricular junction is called the mitral valve annulus, and when we're repairing a mitral valve, we always place a ring around the mitral valve annulus to stabilize it. To have a think about these collagen fibers in the anterior leaflet, they form a parabolic curve, and if you were to imagine that this parabolic curve was a bridge, then the closer the pillars of the bridge are to one another, the more load it can take. And it's the same with the mitral valve. So in various cardiac pathologies, you get dilatation of the left ventricle in systole. And when the ventricle dilates, this curve becomes much more shallow. And so you often get loss of strength in the mitral valve leaflet, allowing it to leak. And this is one mechanism whereby mitral regurgitation occurs with heart failure and severe left ventricular impairment. Now I'm going to just try and cut away some of the left ventricle to show you the posterior leaflet in more detail. Now, here's a view that you sometimes see echocardiographically of the fish mouth appearance of the mitral valve. And this is basically due to P2 and the anterior leaflet. So this is the P2 scallop of the posterior leaflet, which is a sort of minor version of the anterior leaflet. It has a similar morphology. And the anterior leaflet itself is composed of two zones, which are called the smooth zone and the rough zone. And you can see them displayed quite well here. So the rough zone has chordae which insert into the other side of the leaflet, the inflow side, and these are quite easy to see with naked eye. And there's the posterior leaflet again, P2. There is the right coronary artery. There's the left coronary artery. And so these valves of the aortic valve are named for the coronary arteries. So we have a right aortic valve cusp, a non-aortic valve cusp, non-coronary, and a left coronary aortic valve cusp. The cusps are called semilunar cusps because they look like half a moon. And in life, they form a circular group of three, and they meet one another in the midline. There is a little condensation of fibrous tissue in the free margin of the aortic valve cusp called the nodule of Arantius, which helps to promote competence of the valve. The valve leaflets meet each other at these anchor points called the commissures, and in life there is a distension of the sinuses of Valsalva so that we have a corresponding scalloped margin on the junction between the aortic root and the ascending aorta. And that's called the sinotubular junction. You can just about see it here. There, of course, is a corresponding junction between the mitral valve and the sinuses of Valsalva. So together they form a sort of continuous sinusoidal curve which conforms mathematically to a type of curve called a cycloid curve. So that's the aortic root. The aortic root lies between the left ventricle and the ascending aorta, and its components are the sinuses of Valsalva, the ostia of the coronary arteries, and the leaflets of the aortic valve. There is also a thing called the virtual basal ring, which joins the nadirs of each of the aortic valve cusps. The nadir is the lowest point of the line of attachment of the aortic valve cusp. So if you were to join those 3 points together in 3 dimensions, you would form a continuous ring. And that's called the virtual basal ring. So anatomists like to define the aortic root as that structure which lies between the virtual basal ring and the sinotubular junction. And by doing so, they incorporate a new element, which is called the interleaflet triangles. So you imagine the virtual basal ring running here. Underneath each of the commissures is a little triangular structure, and they would be named for the valve cusps. So this would be the non-left interleaflet triangle. So these triangles are very important anatomically and surgically. They're all related to important landmarks. So here's the anterior leaflet of the mitral valve. It's connected to the aortic valve by a small zone of fibrous tissue which merges with the non-left interleaflet triangle. And this area of fibrous tissue is called the aortomitral continuity. The chordae tendineae, which support the mitral valve, come from the papillary muscles. And in life, this would be more like this. What we find when we take out a specimen of the mitral valve is that the lateral the chordae tendineae arising from the lateral papillary muscle are shorter than those arising from the medial papillary muscle. And that's because the medial papillary muscle has to stay back away from the left ventricular outflow tract. If it's too far towards the aortic valve, it may cause an outflow tract obstruction. So we have a rough zone and a smooth zone on the anterior mitral leaflet, and indeed on the posterior leaflet too. And the rough zone has these big coarse bundles of collagen running within it in a parabolic shape. If you imagine that these collagen bundles was a sort of bridge, then the load that could be borne by the bridge would depend on the curvature, and the narrower that curvature, the greater the load that can be borne. And the same is true when forces are considered in tension, and the mitral leaflet becomes unstable as the left ventricle dilates, as it may do in various types of heart failure. And when this curve becomes open, the mitral leaflet is prone to develop regurgitation because it becomes weaker. So there's the sometimes called the fishmouth view of the mitral valve, with the anterior leaflet pressing against the posterior leaflet. So the posterior leaflet has three components. They're called scallops, and between the scallops there are clefts. So this is called P2, and on the medial side we have P3, and on the lateral side we have P1. So we talk about the P3, P2 cleft, if you liked. And these sometimes are abnormally deep and may need to be oversewn as one form of mitral valve repair. If I turn the specimen over, we may be able to see into the mitral valve orifice as the surgeon would see it. And my thumb is pushing down on the anterior leaflet of the mitral valve. And in life, in systole, it presses against these other scallops of the posterior leaflet. Their function is more to cushion the anterior leaflet than to withstand the main force of the ventricle themselves. So once again, we have a P2 leaflet, we have a P3 leaflet or scallop, and a P1 scallop with the clefts in between. Good, well I hope you have found some interest in watching me dissect the pig heart. The pig heart is the one that's very, very easy to get hold of for dissection purposes. And this is well worth doing. And indeed you can practice all the operative procedures on a pig heart very effectively. Thank you.